just telling you. I don't know that I can cram it all in. So, anyway. So I apologize for that, but I'll take responsibility. My brain is too old to keep all those things in there if I do not write them down, so that was my fault. Okay, questions from yesterday, questions about what we're doing tomorrow, anything that's concerning you, worrying you with regards to diabetes. Anything? You're good? All right. So you did really well in the quiz. The average grade was 96%, the lowest was 90. That was really good, very good. Everybody got every lab medicine question. You were 100%. So if that's an area where you're wanting to pull it up, it definitely went up. Yay. All right. So I think the only questions that were missed were in Clin Med, which y'all are usually doing well in. So pathophys, physiology, all those would go well. Okay. All right. So let's start on, let's look at delivery forms. We ended at about page, let's see.
I don't know what time it is.
Page 10. Let me go over just some of the terms we use a lot, and if you're not familiar with the different dosage forms and haven't run into these before.
I started.
From yesterday, just
Okay, why will that not advance? I can advance it here. Okay. Okay. When we talk about an insulin vial, this is what they look like. Vials are great. I love vials, but they require a patient to draw up a dose of insulin. So the pharmaceutical companies have been very relentless at moving people to a dosage form called pens, insulin pens. While they're great and they're a great convenience, they are more expensive, and so there's good and bad on both sides. Vials are much less expensive, so let's just look at them first, so at least you'll have a familiarity with them. Vials are standardized. Vials are always 10 mLs. The reason this is important is because for you to figure out how many days supply you need, or units, or vials, or pens that you need to write for, you've got to know what size they are. Fortunately, they're fairly standardized. So a vial always contains 1,000 units. Okay. So a vial is 10 mLs. Okay. It is 100 units per ml. Okay. 1,000. So if somebody's taking 30 units a day, how long is that vial going to last them? About 33 days. Okay. The other thing to look at, and this is changing, is that all insulins are designated in terms of concentration by these terms. U100, U200, 300, there's a U500. If you do vet medicine, there's a U40. So what this means is that there is 100 units of insulin per 1 unit per mil. 100 units per mil, no, 100, yeah, sorry, 100 units per ml. The closer you get to a blackboard, the less you can. Okay? That's U100. So U200 means there's 200 units per ml. 300, there's a 500. Years ago, there used to be U40s, U80s, U100s, U500 existed at that time too. But what they found is that people got confused. So if you were prescribed the number of units for a U100 and you took U40, you got less. If you picked up a U40 and you were prescribed as a U40 and you did it as a U1 and you picked up a U100, you got too much. So they went and standardized them probably 20 or 25 years ago. And the U40s, U80s went to vet medicine. You didn't see them in human treatment anymore. Well, because we got more insulin resistant and we got heavier and fatter and we require more insulin and more type 2s use insulin, the problem using U100 is sometimes you have to use really big doses. So what they've gone to now is going to more concentrated insulins. Okay. So it's really important to know that when you're prescribing, like if you're doing a Humalog quick pen, there's a concentrated form that's 200 units. But the regular Humalog is a U100. So they've made some things complicated, but in the end, it really does help in terms of patients because you can give a smaller volume. So people who, type 1s, they are usually only going to need, if they're normal size, they are usually going to need somewhere in the range of 20 to 40 units a day. That's about what you put out. If you are not diabetic and you don't have insulin resistance, then you are probably putting out that much. People with diabetes, for type 2, can use as much as 1 to 1.5 units per kilo. So if they weigh 100 kilos, then they're using 100 to 150 units a day. Okay, that's due to insulin resistance. I'm just giving you examples. You don't have to write them down. So that's why these have now become more popular. The other thing, because the drug companies want you to buy their pens, if I'm using a vial, I can more easily meet these dosing needs. A pen has 300 units in it of U100. Because pens are only 3 mLs. Okay? So a pen will last them 2 days if they're taking this kind of dose. So again, the reason to move to these more concentrated forms. So be aware, be aware. Okay, so if we're using vials, and again, the least expensive, you can buy a vial of regular or NPH insulin for $25 at Walmart. And but then you have to teach them how to draw it up and how to inject. You have to teach them that if they're doing pens too, but the actual drawing up is a little different. Okay, look at the bottom, this corner down here. So the insulin vials are insulin is a protein. So it's anything you can do to a protein. What can you do to a piece of steak? I can cook it. Does that change its appearance, the way it is? Okay. Can I freeze it? Yeah. Okay. Does it change it? Yes. So you can do the same thing to insulin, to a protein. If you cook it, it will denature it. So the warmer it gets, the less stable it is, and the more it goes bad. The other is that if you freeze it, freezing doesn't tend to be as bad a problem as heating, but freezing we don't ever recommend. So we usually want people to keep them at either room temperature or cool. But I'm pointing this out because if they become unstable, they change appearance. So one of the things we always teach patients is if your insulin changes in appearance, you need to take it back to a pharmacy and probably get it exchanged. In Oklahoma, I have found this to be a problem. Here's an example. I had a guy who had seen for a long time, who'd gotten his blood sugar pretty well stabilized. This is when I was practicing out of the VA. He called me one day in the middle of the summer and he said, my blood sugars have just gone crazy. He said there are 200s, 300s, and I cannot get them down no matter what I do. And so I went through my usual questions. Well, what have you done differently? Have you skipped any doses? What's different? Are you sick? Have you been ill? Do you think you have an infection? All the different questions. Finally, I said, I'd run out of everything I could think of, and I kept hearing this weird noise in the back, and I said, what is that? And he said, oh, I'm outside, and somebody's sawing, this was rural Oklahoma, he said, somebody's sawing a tree down. I said, what are you doing outside? This was a summer, it was hot, it was like 100 degrees already, it was probably midday. And he said, well, I'm outside because it's cooler out here than it is in my trailer because my air conditioning went out. He said it's 106 degrees in my trailer, but it's, it's only 100 degrees out here. I said, okay, well, where do you keep your insulin? He said, I keep it on the little windowsill above my kitchen sink. Well, it had just fried. I mean, the insulin was just cooked. So when we replaced it and started keeping the refrigerator, his blood sugars went back down to normal. In 2 weeks of over 100 degrees, insulin is denatured. It's a real problem. When I first moved to this state and I worked for the hospital, it was a real problem because they would ship the insulin and it would sit on the dock in the middle of the summer. I'm like, okay, we can't keep doing this. It just denatures it. So now they usually ship everything in dry ice. Yeah.
So when you said you can exchange it, is it free for them if they take it back to the pharmacy, or do they have to pay for new?
Well, I hate to speak for pharmacies because they get pounded, but yes, they could take it back. It's reportable. You have to report it. And sometimes they'll come out with, the FDA will come out with notices about lots that are not good.
Okay.
They have worked a lot of these problems out. This is from quite a while ago. This was a NPH human insulin. And the more you took out of the vial, the more unstable it got. And so it would easily precipitate out or frost over the bottom, crystallize out. Okay. Questions about that?
I think it depends on which pharmacy you work for. Because like the big chains, it takes a lot for them to take medicine back.
If your insulin doesn't look good, I don't know how they can refuse you. I think you could report them.
I mean, people who took
It doesn't surprise me what you're saying. It
Yeah,
doesn't.
they never brought it back, but I know like for other medicines, like we can't take it back.
Well, now that's true.
Yeah.
That's true. But for this is a different story. But you're right. You can't. Once you dispense medicines, you cannot take them back. And you could take them back and destroy them, but you can't take them back and redispense them. That's the.
Or we didn't even take them back to destroy them.
Okay, well that's the chains.
Yeah.
That's I understand. I understand why they do.
I'm sure maybe like the small town pharmacies out in rural Oklahoma might do that, but as for a CVS, probably.
Probably not. Okay. Insulin pens, they come as a cartridge instead of a vial. Questions about the vials? Here are the pens. They look like pens. They've been around since probably the late 70s. And they are purely meant as a convenience item that you can carry with you more easily. That's why they were designed. So the pen this is a typical pen regardless of who makes it and what insulin. So this is the built-in cartridge. These things are usually made of plastic. There are some that are metal that you could put new cartridges in, but most everything is disposable now. So the cartridge is here, and it contains 300 units. The patient can see it. They can see the insulin. There's a window, and it's plastic, and they can see it. So they can look at the insulin before they inject it. They all, so here you see this is what it would look like for many of them. A needle has to be placed onto the end. When you're drawing up a vial, you've got a syringe that has the needle permanently attached to it. Here they have to attach that needle. You have to write separate prescriptions for that. It's the weirdest thing, I think, is that you've got a device, there's no way you can give it if you don't have the needle, and they have made them separate things. So, two different prescriptions. Every pen comes with a dial. Now this is, I think, an advance and is helpful. So they all come with a dial that you see in the upper right-hand corner that the patient dials their dose. It can go forward, it can go backward. So that's nice. They are limited though. If you've got a person who's on a dose greater than the dial, that means they have to do 2 separate injections. That doesn't happen very often. So they can dial their dose. Some of them put a actual little magnifier plastic over it for patients who have trouble seeing. That's one of the troubles in drawing up your insulin, is that some of the scales on the smaller syringes are harder for people to see. And they're harder to manipulate. If people have arthritides or if they have neuropathies, then drawing up insulin really does become more difficult. So this is greatly an advance in that regard. Once this is assembled, once they have dialed up their dose and they've got the needle on, then you pretty much inject it the same way you do if it was a syringe. The needles are very fine. They are usually in the range of 31 to 33. The higher the number, the smaller the gauge. So patients like a higher number, higher gauge. Why it is that way, I have no idea. And the other thing that's different is the length of the needle. So needles go from anywhere from 4 millimeter to 12 millimeter. Patients like those little 4 millimeters because they go in easily, and they don't look as intimidating. But sometimes they're more difficult, especially if you have to put a large volume in a subcutaneous space. These are all designed to go subcutaneous. If you have a big depot that you have to put into subcutaneous tissue, if you've got too much, it'll come right back out. It just comes right back up the track that you created when you inserted the needle. So I like at least the 5 and 6 millimeter. But patients, once they figure out there's a 4 millimeter and they've used it, they will fight you tooth and nail to go back to it. Or that's been my experience. For really large doses, I like the 8 millimeters, but patients hate it once they've seen it because it really is a little bit more intimidating. I don't know that anybody uses the 12 anymore, but. So once they inject it, you see that there is a button back here that they press to actually, it's piston driven so that cartridge sits on a piston. And when you depress that button, it just drives the insulin into the body. Those can be difficult. They are not easy to depress and move in, especially when they've got big volumes. So working with a patient, making sure that they can use one is important. The injection techniques you teach them are the very same as what you would do with a syringe. In terms of prepping the area, how we insert it, you see they're going directly in, 90-degree angle. Okay? So we never go at side angles because we want it to go into that subcutaneous space. Questions? An insulin pen. Here are some of the new concentrated pens. This was probably one of the first ones to come out. This is Toujeo. It's just the brand name. Insulin Glargine, so if you're familiar with Atlantis or you know that name, it's the same insulin. What they did is they made it a much more concentrated insulin because a lot of people who are using these may be taking 50, 60 units at a time, maybe once or twice a day. So it has 450 units in a 1.5 ml pen. Okay. So it has more units in less volume. Now, the one good thing they did when they made the pen is they took the conversion problem out of the hands of the patient, which was a smart thing. So that you just tell the patients how many units you want them to take, the pen takes care of that in terms of converting it from what you've said and what a U100 pen would do and what this pen will do. So that's a nice thing. Same kind of thing, same setup, has a dial. Insulin's here, and it works by depressing a button. So here you see the volume up in the left-hand corner. Down the lower left-hand corner, you see the surface area and the droplet, what it looks like, just more concentrated. And then you see on the right-hand side the kinetics. So pretty similar. You've got Lantus can have a slight peak to it right after you take it for about 5 hours. Some people notice it, some don't. But this one tends to flatten that out a little bit, 2JO does. And maybe a little bit longer. I found patients did a little bit better on 2JO this is just N of 1 experience again. They did better on large doses. I often would convert them over to 2JO because they seem to do better. Honestly, what I think it probably was, it's a new device, maybe it's better, they took it more often. Probably more adherent. But sometimes I would get a better response for people who took large amounts. Here is the Humalog U200 Quick Pen. Now, Humalog is a bolus insulin. 2JO is a basal insulin. So basal means what? Long-acting background, usually once a day, sometimes twice a day. When I say bolus insulin, when is it given? Always before a meal, usually, almost always. So rapid acting, so this one is a U200. Again, usually the size of a bolus dose is small. But even in somebody who is type 2, high insulin resistance, they may take 40 or 50 units before a meal. Okay? You probably put out 2 to 4 to 5 units before a meal, with a meal. Okay? So again, this is just a concentrate. And it has 3 mils, so it actually contains 600 units, so you're getting close to what a vial would. So the pen will just last them longer. Pens always come boxed as 5 pens in a box. Most pharmacies will not break the box. So they'll look at, that's 1,500 units, it will last X amount of days. I have run into times where they would do it because that's what the insurance did, but usually the insurance will pay for a box of 5. So that's kind of your dispensing unit. You run into anything different?
We would just bill the days differently.
And that's what you do, you bill the days differently. So what the pharmacy has to go in and do is, and it gets tricky. I found it's better if you write for a 30-day supply, because if you write for 1,000, let's say you wrote for a pen that had 300 units, and let's say they're taking 10 units before each meal, so that's 30 units a day, and so that pen's going to last them 10 days. So if you write for 15, if you write for a box, then what they're going to do is it's going to be a 50-day. That's what they would put in, right?
And then if the insurance kicks it back and says we'll only pay for 30, then we.
Do you break a box then?
No, we'll do a whole box for 30 days.
How do you do that? Don't they look at the number of units? Not so much, okay. It's what you put in.
Yeah, I think with insulin, since I was told that you are technically not supposed to break a box, and that if you do, it just is more hassle than it's worth. So
It is not worth breaking a box, but I've had pharmacies who do that. They would only dispense 1 pen if it was something that would last a 30-day.
Yeah.
But after that seemed to be for a short period of time, and they reverted back, so.
Well, we'll have like practitioners who only write for 1 pen, like they go to the ER and they're like, oh, you need insulin here, here's a pen to get you the 10 days, and then you need to go see your primary care, but we would always do a box.
I'm telling you, you will get more calls on insulin because of this, because of days supply. So that's why I'm driving it home, is that know how much volume is, know how much it's going to last, and remember that the pins come in groups of 5. Vials come one at a time. Okay. So a vial, 1,000 units, pins, 1,500 units per 5. That is also the drug company behind it, saying, you get a box of pins, you get more than you get in a vial. It's all their little marketing ways to do things. Not bad, it's just the way it is. Okay, let's see.
And Dr. Latassi, the whole needles thing isn't an Oklahoma state law. It's a Oklahoma City ordinance and a chain, or in a pharmacy preferred thing. So like, if you go out to roll, you might not need a prescription for,
Syringes, but I've not seen that with pen needles. Here's what she's talking about. So, because the insulin came out in 1922 and the rules that came over what was constituted a prescription were in the 60s and 70s, insulin has remained in the OTC status all that time. So NPH and regular are not prescription items. So as likewise, along with that, syringes were never prescription items. But because the drug dealing became such a problem, a principality, so Oklahoma City can say, you must have a prescription to get syringes. But what she's saying, and this is true, you could go out to Godibo and go to the pharmacy and get your insulin and your syringes without a prescription.
I thought pen needles fell into that category.
I don't think so, but I am talking more out of what I suppose instead of actual experience. But that is true with the syringes. Okay. Oops. This one's just showing you the concentration. Same dialing situation. You'll notice there it says discard after 28 days. So the pins become less stable, smaller concentration. So some of the pins are only good for 14 days once you start using them. Pins also are to remain at room temperature. I'll go through the stability and stuff. So the pharmacist should tell them. But on some things, if you are prescribing them frequently, you need to know which pins are for 14 days, which are for 28 days. Most of the pins, though, are 28 days. Most of them should be kept at room temperature once they start using them. I'm going to spend a lot of time here because this is a whole nother topic, but another delivery method are insulin pumps. Are you familiar with the pumps? Is this something you've heard about before? So they're very small, they're about the size of a credit card. And they are a little computer programmed device that has a reservoir. Let's see if I can see. So here, this is the reservoir behind here. And it can hold usually about 300 units of insulin, usually 200 to 300. So we use rapid-acting insulins in these devices. So usually it's going to be Humalog, Novolog, or Apidra. They're all pre-approved. There is usually a very long tubing that connects it to a catheter that is inserted into the subcutaneous space. So on the left-hand side, you see that's the device that they use to insert. So there's a silicone covering over this needle. You put the device to your skin, you punch a little button in the top, which he's got his finger on, it inserts the needle. It's clean, slick. To me, it doesn't hurt. It inserts that needle, and the recommendations, you leave it in place for 72 hours, then you change spots. So you can inject into that area for that length of time. So the catheter connects you and that site together. You can get tubing as long as you want, so you can wear the pump anywhere you want. A lot of women will put them on their bra straps. I've seen a lot of men put them down in their boots. So the pump can go anywhere, and then the tubing connects you to that. The pump is programmed. It's programmed to deliver a basal amount, and then it's programmed to deliver a bolus amount. So the basal amount, you can put in 24 different basal rates a day. You can change basal rates every hour. Most people have at least 3 basal rates throughout the day. You have one that delivers a little bit of insulin at night. Some people need more when they get up in the morning, and then it changes in the afternoon or the evening. So by working with somebody who is a pump specialist, so I used to do pumps. You'd go through training, you become certified, then you train people how to use pumps, and then they come back to you, and you look at their data, and you help them get to the point where they can usually get a basal that works. The other thing that is required is they have to know how to count carbs. So that's one of the reasons why I put some of that in your objectives, is because anybody who's going to use insulin intensively has to know how to count carbs in their diet. And we established insulin to carb ratios, and we'll talk about that a little bit later this morning. So when a person's looking at what they're ready to eat, they can then dial up, and there's a wizard like you have when you're setting up a program on your computer. There's a little wizard that comes up, and you can put in, here's how many grams of carbohydrate I'm going to take. You can do a finger stick blood sugar. It will communicate it to the pump, and the pump will take into account when did you last bolus, what insulin do you already have on board, and it'll say, here's how many units of insulin you need to give yourself. And then you have the ability to say yes or override that. The other cool thing about, so it can bolus. If you're having highs, you can use it to correct. We'll talk about how to determine an insulin correction dose. The other cool thing that they can do is they can deliver insulin in different patterns. So when you eat, like I was talking to you about pizza, or I find Mexican foods the same, we can use a square wave. So you're going along and you're taking bolus insulin, you're going to eat pizza. The problem with pizzas is that, I told you that fat delays absorption, but you get initially some bump out of the pizza dough itself, and then you get later this other rise in blood sugar. So, or you can do this kind of pattern. Or you can have it give you a bolus here and a bolus there. It's cool. They are very sophisticated machines. So you can really fine-tune somebody's blood sugar with a pump. But it's high maintenance. You've got to do your blood sugar at least 6 times a day. You have to pay attention. You have to change that site. If it gets infected, you have to go back to needles or syringes or a pen. So you've always got that backup. So they require a lot of effort, but there's a lot of payoff. They're waterproof. Some of them are. So you can swim with them, shower with them. They're very flexible. Questions about that?
You just dump the vial into it?
No, there is a special device that comes with the pump that fits on a vial, insulin vial, and you can draw it out, and that is your cassette. So the cassettes have to be changed about every 3 days because they're being worn close to the body, that your temperature will cook the insulin. So we change out insulin cartridges about every 3 days. The good thing is that when they go into the person who oversees their pump, you can download it, and it'll do these massive printouts, or you can scroll through it, and it'll show you exactly what they've been doing, what their blood sugars have been. They have alarms on it, so if the catheter occludes, it will alarm the person. I think what else.
How much are these pumps?
Pumps, the last one I was doing them, they ran in the 3,000 to 5,000 range. Now, so because of that, they're an investment. The companies will usually cover them, but there's lots of things that they require. So they require usually that you've been a diabetic at least 6 months using injections. They also, you have to show that you will do finger sticks 4 to 6 times a day at least. You have to go through education. So there's lots of things they'll document. They've opened up the market more to type 2, so type 2s can get on them. I've had patients who are really old on them and do very well. And lots of the kids, they will start on pumps pretty quickly after they get them stabilized. A lot of pregnant women will go on pumps just because the ability to control well is optimized with these devices. But there are a lot of people who get on them that within a few months are like, not doing this. They are high maintenance, so as providers, what we do in family medicine is we taught the providers, here is a good pump candidate. So don't send us people who are not going to do it, not ready or not willing, because it's a lot of money. The catheters cost about $150 a month. Insurance usually covers those. Or a good amount of them. They have to monitor a lot. Monitoring takes a lot, glucometer strips, so they have to be able to do that as well. They always have to have a backup of insulin pen or an insulin vial, so it's a lot of money. But you can get really good control, and that pays off in the long run for the insurance companies as well, and society and the person. Questions? So we're going to go through some of the terminology that people with intensive insulin therapy and on pumps would use, so that if they're coming into you, whether you're doing that part of their regimen or not, you will at least be conversant with them and can talk to them. So when they talk to you about insulin to carb ratios, or when they talk to you about sensitivity factor or correction factors, you'll know what that means, whether you do anything with it or not. Total daily dose of insulin, their basal, their bolus. You're already starting to learn some of that. Okay. Anybody have experience or story they want to tell about pumps they've run into? Taylor, did you ever do?
No, I've
Sorry.
rotated with at a diabetes clinic, but I didn't have that much experience with them. More so the carb counting side.
Yes,
But
yes.
My brother has one, he has type 1 diabetes. He won't tell me a lot about it, but he's had it for years, and it seems like it works fine for him.
Did they start him pretty soon after he was diagnosed?
I don't know, because I was moved out when he was diagnosed. I was across the country. I think maybe like a year or two. He has really good insurance, and he still spends hundreds of dollars a month. I just asked him, he's probably still asleep, but I'll, until last 3 hours back. But yeah, he complains sometimes about how much he has to spend, and that's with really good insurance. So I can imagine if he did not have good insurance, and that's insulin, syringes, all the stuff.
Yeah, because you waste a lot of insulin. If your type 1's well controlled, you're not going to use a lot. If you use 40 units a day, and you're filling up a 300 mil cartridge or unit cartridge, then you're wasting half of that every 3 days. So they have moved to 200 unit cartridges. I don't remember now if you can underfill a cartridge. I just don't remember. I think not, but I could be wrong. Yes.
I had a mentee in the program that I did who was type 1 diabetic, and she had had a pump for as long as she could remember. She was diagnosed really young, and her mom's a dentist, so she's like very kind of health aware. But I mean, she had one forever, and she was really good about doing it. I remember taking her out to eat it one time, and I was just like, I don't know. But even at age like 8, like knew how to do it. She's a smart girl and knew how to do it herself, and you know, she's able to do pretty much everything else that any other kid is able to do. She's an amazing softball player and has her bump on her. And
You might not even know someone has one unless
Yeah.
you see their tubing.
Exactly. There are a lot of football players that have type 1 diabetes that play, and you learn how to manage that intensive exercise and do the carbs. That's why I put in one of those standards of care that I gave you is how do you manage somebody who's going to exercise? So knowing those broad things is helpful, because it might be one thing you'd ask someone, you know, okay, you ran out of gas when you were doing your run, did you use a carb before? What are you running before? One of the dietitians I worked with at Family Medicine was type 1, and she did half marathons a lot. And she had it down, never got low. Okay. So this shows you how a pump works. I should have showed you this earlier. So that shows you where your infusion set is. You see the catheter. And those catheters, you get them as short or as long as you want. I think the shortest are about 28 inches. The other long ones are really long. I mean, you get tall guys, they can put I don't know why guys like it in their boot, but that's where most of the guys I saw did it was in their boot. Anyway.
Oh.
Oops. So that's what it looks like. Now, the device that's over on her right-hand side is a continuous glucose monitor. So it's we call it CGM. That one you can wear for 5 to 7 days. It collects your blood sugar in interstitial fluid, a little bit different from capillary. But you can take it off, download it, and match it up with what your pump is doing, and you can do amazing things. That's why they can get such good control. That's why athletes like it, because you know what's going to happen. You know if you do this, then you change this on your pump, so it's very flexible.
So is this as heat sensitive too? So if they're like working outside and it's 100 degrees, is it gonna affect the insulin that's in the?
It will, but it will not affect it within the 3 days that they're going to, because that's why you've got to change it out. You know, like if you go to the beach and you lay your, yes. Okay, let's talk about syringes. This is on page 11. So knowing the parts of a syringe, so the barrel, that is where the scale is. The scale can be very different. If we're dealing with infants, babies, we can get down to syringes that will show a half or a fourth of a cc. So they just spread that scale out over the barrel so that you can get very accurate readings or measurements. Plunger goes without saying. The biggest problem I have always to teach patients is that you never have them fill up a syringe. Because we have, this is a 30-unit syringe, it'll hold 30 units. We tell them don't fill it past 25, because if you fill it too full, the plunger comes out the back, you lose all your insulin. So it's practical more than anything. The needle is permanently attached. You don't have to fix it to the end. It's already attached. This is called the hub, and we always insert the needle subcutaneously to the hub. So they don't just prick themselves and then inject. It's always to the hub. And so that when you are looking at the size or the length of the needle, it's from the tip to the hub. We use this, you can see the top of the tip of the plunger is black, and the tip is fairly is visible. That's what we use to measure the insulin, to the tip of that plunger, black plunger. You'll see that syringes come in all types of sizes, or the volume that they will hold. Okay, so this one is one more that probably type 2s would use if they're drawing up their insulin. It will hold 100 units. That's the largest one that's on the market. They are marked off in units of 10 visually, but in between each marker is 2 units. The next three down are called low dose. So if you're going to order syringes, you need to specify the volume. So you put a 1 cc syringe, that would get you that largest one. You can put in a low dose. Most pharmacies would fill a low dose with the 50 unit. So 50 units, again, it's marked off in 5 units. Each mark is 1 unit. I always keep patients on the same syringes because you see the difference here. 1 hash mark on the low dose is 1 unit, 1 hash mark on the larger one is 2 units. Okay? So if patients ever go down in volume, or I had some patients who drew up their basal with 1 size syringe and they used another size syringe for their bolus. There's a 30 unit, that's pretty common, especially for people who are insulin sensitive or type 1s. And then you go down to the next one, I think is also a 30 unit. I don't have one with a little half. They make a 25 unit. So again, the smaller the volume, the more you want to be accurate. So I don't want somebody who's using 10 units of insulin to use the larger syringe. I want the smallest syringe that will hold that volume because it'll be the most accurate. So you can see why the pens have greater accuracy because all they have to do is dial a number. If you start to wonder if you really can't figure out what is going with somebody's insulin regimen, have them get their stuff out and show you what they're doing. It will shock you. So going back to the pens, let me tell you one thing that I have seen this, and I saw it in I saw this in a journal the other day. Okay, so see that needle, pin needle? It comes with a covering. It comes with 2 coverings. When you take a pin needle, they are all individually wrapped. You take it out of the box and it's got an adhesive covering that you remove that will allow you to attach it to the pin. But it has a covering over the pin needle and then it has a plastic cover over that. Okay, so it's protective. It keeps it sterile until it's ready to use. Well, what they have found is people took that first covering off, didn't realize there was a second covering, put it to their skin, injected. I don't know where the insulin went. I don't know why they wouldn't think, why is that fluid all over me? But they weren't getting the insulin injections because nobody told them, I guess, or they didn't listen, or they couldn't just take it all in. That you have to take that covering off. So those are simple things you learn over time, is to start asking people to show me how you do that, because you will see some interesting stuff. When I worked in the Harold Ham, we started having a lot of pool nurses that worked in and nothing against the nurses. I'm not saying it about them. I'm saying about probably weren't shown, not familiar, asked to do something they didn't know anything about. But what we've discovered is that they were taking out the pins, giving an injection, but never putting a needle on. You have to attach it. So, well, I mean, there's jet injectors that you just put up to the skin and push it and it goes in. So what they were doing is, I don't think I have a picture to show you, but it's just a latex surface with a holder around it. So they would put that up to the skin and inject. Again, well, there you wouldn't know, but the resistance would be pretty high in the pen. That's what I'm not quite sure how they justify that. Anyway, or rationalize it. Anyway, so I'm telling you, lots of ways people can mess up. The higher it requires the person to do something, the more likely there's going to be errors. Here's another one. So this was about a meter. So the meter is digital in its display. So a man was diabetic. His wife had been taught how to do the glucometer checks. He didn't want to do them, so she did them for him every day. So nurse educator gets a call and says, my husband's sugars are 500. And so she was walking through, it's like, okay, well, is he complaining about this? Is he complaining about this? No, 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 no. Couldn't figure it out, couldn't figure it out. Finally had him come in and said, okay, show me what you do. So the wife has the husband sitting there, she's doing the meter, but the meter is upside down to her. So the 200 looks like a 500. Yeah. And another one. So it takes a lot of investigation. You have to know your device as well, and then sometimes you just have to have people show you what they're doing. So we had a person call in one day and go, my sugar's 14. Like, okay, 14. Well, how are you talking to me? And, okay, so tell me more. Are you feeling low? No, no, no. Well, then what we figured out is that on these, especially meters that are sold overseas, theirs are in millimoles. Yeah, so they had flipped it. Or patients will play around with their meter and they get it in Spanish and then they're like, I can't read it. Some of them are like in 14, different languages. So they change it to see what it looks like, but then they can't read it in order to change it back. Diabetes educator humor. All right, let's see. We'll take a break at 10. Okay, here are the needles, and these are called pin needles because they screw under the top of the pin. So what you see here are the links and the gauge. So the links, like I told you, those 12.7s, nobody wants those. So 8 is short, 6 mini. But when you write them, you're usually going to write them for the length, like 4 millimeter or 6 millimeter. Personally, I like the 6. They do make a 5, this just doesn't show it. I like the 8, but most patients want it, they like this 4 to the 6. Okay. So when you would write the prescription, you're going to have to write the gauge. Okay. Again, the smaller the gauge, the more comfortable it is. So they do make gauge, they do have to go up to a 33 now. But 31, 30 and up is pretty comfortable, 31, 32, yes?
Doesn't it depend on like how much subcutaneous fat they have too? So like if they're a bigger person?
No, because you want it in a subcutaneous fat. The thing that I think is the problem is the volume. You just cannot put a small volume in in 4 millimeters, you just can't. So if you're giving 60, that's why I like the 8 millimeter. Put it in deeper, it doesn't come back. So when we teach people to inject, we teach them to inject, count to 5, and then pull it out. If you inject and pull right out, the insulin comes right back up that track until it settles down. Give it 5 seconds, it usually will settle in, it won't come back up. It'll bead up. They'll tell you that after I give an injection, it beads up. Or if they tell you, I get a welt, or not a welt, but a mound. Like a blister, well, they haven't injected far enough. That's right under the skin, and it's a fluid-filled insulin sac. Storage of insulin, so let's talk about those. We talked about heat. We talked about freezing. Don't do either one of those. They are sun sensitive, so we don't want them to put it up on the kitchen seal if the sun's going to come in. I always tell people, keep it out of your bathroom and your kitchen because the temperature changes and humidity changes in those two rooms are usually the highest. Usually tell them, put it in your bedroom, put it in your dining room, if that's where you'll remember it, is better. Don't shake it. Shaking insulin will denature, destroy the protein. The reason why people would shake it is that some insulins, particularly the mixes of a basal and a bolus, come as a suspension. And they have to be resuspended if they sit long enough. So when we resuspend, we just roll it between our hands. Okay? Never shake it. Shake it enough, the insulin quality will start to go down. Questions about those? We teach patients in the, when we're putting them on insulin about what their insulin should look like. So some insulin is clear, always should look clear. We teach them to inspect their insulin every time they inject. If there are things floating in it, that's not good. If it's changed color, that is not good. If it won't resuspend and it's a suspension, not good. Lantus is probably the most problematic of any of the insulins because it's more temperature sensitive and pH sensitive. So if you carry that one around with you all the time in Oklahoma heat, it usually will start to turn color or it'll precipitate. So one of the things you could ask patients if they're telling you, you know, my blood sugar is terrible, you've gone through all your list, then I start looking at where are you storing it, has it changed appearance? Is one of the questions sometimes I will ask. I also can use this to my advantage. A patient comes in, what's your insulin? I don't know. What's the name of it? I don't know. Is it clear? Is it cloudy? Then I can start to figure out what are you taking. Because there's not very many that are cloudy. So I can figure out from there. Compatibility. Do not mix insulins unless you know they're compatible. Don't ever change a dosage form unless you know that what you're doing will not change the integrity of the stuff. You're going to see people do really weird stuff out there, and I'm talking about providers. The things that they will tell patients to do. Just tell them, Dr. Ledesky said we shouldn't do that. And they'll go, who the hell is she? So, insulin that are compatible, the manufacturers have already figured that out and they have put them together. So there are a lot of commercial products that have mixtures together. Those are usually the cloudy ones. They're suspensions. So Humalog comes as a mix. When they say it's a mix of a basal, long-acting, and a short-acting, or rapid-acting. What they do is they add either proteins or crystals to the solution that allow it to have two different profiles. So a Humalog mix, 75-25 or 70-30, does this. You inject it, oops, and it does this. Okay? So those mixes have a short-acting in it. The smaller number is always the bolus percent. Okay? 75-25, 25 is it's 25% rapid-acting. The 75% is the basal part. Know what those numbers mean. So when you inject it, that 25% will cover the meal that you have just injected before, and then it will tail off and it will give you basal coverage for usually 8 to 10 hours, something like that. Okay. So if you inject 30 units of a 70-30, and that's the way we usually talk about them. What do you take? I take a 75-25. Humalog or whatever brand they're on. If they're on a 70-30 and they've done 30 units, how much is their basal? This is not hard. 30, and if it's 30, then it's 9. Okay? So they just injected 9 units of a rapid-acting insulin and 21 units of a basal. Need to know these because sometimes you have to convert and you have to change them to something you can figure out. Or if I'm trying to change a dose, I need to know how much they got in there. Okay, 75-25. They've taken 40. How much of the basal? How much is the basal? 30, and the rapid is 10. Okay. Be able to do that, know what those numbers mean. Know that one's basal, the other's bolus. Okay, next page 13. So people will refer that use them a lot professionals are gonna use these kind of terms. They're on a mix, they're on a premix, they're on a 70-30. That's what they mean, is they're referring to these commercially mixed. Okay. So you'll see a lot of them are NPH and regular. Those are Humalog, those comes as pins. These are always pinned. Well, not always, you can get a vial of them too. On the page before that, Humalog mix is neutral protamine Lispro. Protamine is a protein. You stick it in a solution, the insulin will adhere to it, and then over time it will detach and be absorbed. And then it's 25% Lispro, so it's the rapid acting. Same with Novolog mix 70-30 aspart protamine suspension. We have 50-50s, so we've got Humalog 50-50, it's 50% basal, 50% rapid acting. Okay. Lantus and Levemir, never mix them with another insulin unless you've looked it up and there is data, or call the company, call a pharmacist and say, can I mix these together? Humalog and NPH can be drawn up in the same syringe if it's given right away. When you start mixing insulins, you change kinetically. You have the potential to kinetically change their release properties. Okay. That's the reason why. Questions? Yes?
So, do people just prefer the premix because it's less injections?
Sometimes. Usually the premixes are 2 injections a day.
Okay.
So with a type 1, I think the only time you would do that is when they refuse to do anything else. Or you had somebody who mentally could not handle, they have cognitive impairment that they could not handle a more complex. So that's the only time I see it with a type 1. The best you can do usually with 2 injections a day is about an 8 to 9% A1C. In a type 2 though, we use them more frequently. And we'll use them in conjunction with oral agents. So they have probably, I think, more widespread utility in the type 2s. The problem with premixes, is that they are fixed, okay? So there's not a lot of flexibility. The variability in people's blood sugars is based on usually the carbs that they're eating. They're eating variable amounts of carbohydrates, and they're on a fixed amount of insulin. Your body doesn't say, I'm only giving you 20 units today, that's it. When you eat, I'm giving you 5.